Good to see friends and be with two leaders in the field, Lizzie and Elena. So I'm happy to try to go quickly through this to save time for questions. We'll start with the case since that's what most of us do in the clinic is see patients. So this is a relatively common case, I think. A 77-year-old male who comes in with typical symptoms is found to have an ulcer in the gastric fundus. This is confirmed as an adenocarcinoma. Patient's otherwise healthy, and the scan just shows a perigastric lymph node that is highly suspicious. And the lap staging, which is critically important to consider in patients with gastric and even some distal GEJ cancers, was negative. Start with a question. This patient comes in, is family full of doctors. What would you say right off the bat? So 2/3 of people said biomarker testing might help. And I think I'm going to try to convince you that that is the right answer. Okay, so this patient turns out to have the classic sporadic pattern for gastric cancer. If you see MLH1 and PMS2 lost together, it's quite interesting. This is very typical for gastric, but it's not the most common pattern for colorectal. Notably, the patient is not HER2 positive, and HER2 amplification is essentially mutually exclusive with MSI-high, and PD-L1 was not tested. So we're asking if there's a prognostic role and do these results actually change anything you do in the clinic. So little background on mismatch repair deficiency or microsatellite instability in gastric cancer. This on the left is from the TCGA, which is primarily non-metastatic surgical samples where they looked at relatively deep sequencing, so whole exome, methylation profiling, and a little bit of surface proteomics to try to bind patients together by shared biology. And one of the things that fell out was that there's a group of MSI-high cancers. In their series, it was 22% of all gastric cancers that they tested. In real world data from trials, we see that it's probably more like 7 to 10%. And I'm just giving you some examples over there on the right. And then within that MSI-high, you could start to see some clues about, who are these people clinically? One thing you see is that it's uncommon and diffuse. So if you look at that arrow over there on the left, you see that it's a low proportion of the diffuse compared to the intestinal type. And if you look at the median age at these patients, you see that MSI-high patients tend to be a little bit older. And in fact, if you look at patients over the age of 75 or 80, some of the reports have suggested a prevalence as high as 30% for MSI-high. So it really underscores what Elena was saying about the need to test. If you look at the metastatic disease, it's a little bit less common, somewhere in the 3 to 5% range. And that may be just because these patients have a better immune surveillance mechanism. So the question was about prognosis and benefit. The one thing that fell out, and Lizzie knows this data as well as anyone because she was involved in some of this and earlier analysis as well in JAMA Oncology, but asking a question, if you give perioperative therapy, in this case MAGIC or adjuvant chemotherapy in the classic trial, and you look at this biologic subgroup, the MSI-high or MMR deficient patients, how do they do? And the first thing you see is the red line is the highest in everyone. And those are the people, that tells you something about the biology here, and I'll show you a little more on the next slide. But these people have a favorable prognosis, similar to colorectal cancer. And it doesn't seem to be improved on if you give them adjuvant or perioperative chemotherapy. So it makes the argument, as Elena hinted at, that these patients should be considered for upfront surgery, or I'll try to tell you that maybe we should prefer upfront immunotherapy. But the totality of data suggests, and this is retrospective from pooled phase 3 trials, that these patients don't really benefit from perioperative or adjuvant chemo. All right, so back to our case. You convinced this patient that there's a role for MMR testing. It was mismatch repair deficient. And they want to know, what are you going to do with this information? There's a bunch of trials, but can't come in for a trial. So they ask you, what do we know about immunotherapy in localized gastroesophageal adenocarcinomas? And can I keep my stomach? Very common questions. All right, so this is a little bit of knowledge test, pre-test before we get into the data, but which of the following is most accurate about mismatch repair, MSI-high, and non-metastatic cases? All right, so a little bit of a more even split. About 43% of people said D, and about 33% said B. So it's a discussion about the path response rate. All right, before we get into the data, it's really always important to understand the concepts and the rationale for why we do the things we do. So There's really two approaches to immunotherapy in the non-metastatic setting. There's adjuvant with checkmate 577, where the tumor has been removed, and now we're giving immune checkpoint inhibitor with the hypothesis that there may be some micrometastatic disease left behind, and immune checkpoint inhibitors can reinvigorate an anti-tumor, primarily CD8 T cell response. Problem is there's not as much tumor left behind, so the response is relatively restrictive. As opposed to the setting where the primary is still intact, you have a more diverse T cell response, meaning both quality of T cell receptor and diversity of T cell receptor. And this has been shown in a really nice mouse model. Actually, in breast cancer, they showed it, but they've now expanded this to other tumors. And I think the clinical data has really kind of borne this out. So the French actually tested this and probably were the first to do it. And credit to them for this really wonderful trial that was published a few months ago. So they basically said, we're going to take MSI-high or mismatch repair deficient patients, localized surgical candidates. So these are T4, any node, T2 to 4, any node nodal status. It's a single arm phase 2 trial looking at a pathologic complete response rate as the primary endpoint. And they gave neoadjuvant ipi-nivo at sort of standard dose for 3 months. They got a scan. No reason not to go to surgery. They went to surgery, and then they completed adjuvant nivolumab for a total treatment of a year. And then if you look at the primary endpoint, you see that 59%, so the answer was D in the prior question, with which I said about 60% had a pathologic complete response rate. But it's equally important, and I think as we're understanding more, a major pathologic response rate, which generally encompasses a complete pathologic plus a TRG1, and 2, where you're looking at sort of less than 10% of patients, is almost 80% in this approach. So biologically very active, large portion of patients have favorable pathology. And then if you look at the more important outcomes, which is event-free survival and overall survival, you see basically a flat line. And this is relatively short follow-up, but it's highly encouraging to suggest that the strategy of neoadjuvant immunotherapy in mismatch repair deficient patients, so again, theme is biomarker selection here, is very associated with very, very favorable outcomes. So there's a few other data sets that are worth sort of being aware of. This is presented at ASCO GI from our Italian friends. This is the Infinity trial. They asked a very similar question with a broadly similar approach. So very similar patient population. In this case, durvalumab and tremelimumab. So one dose of the CTLA-4, and then followed by durvalumab in the neoadjuvant setting. And then cohort 1, where people got surgery, which is the standard of care. And cohort 2 is quite interesting and gets at the second question I had mentioned before that the patient asked, which is, can I keep my stomach? But right now, we don't really have data for that, but there's a lot of data that will be coming in the near term. We also have seen some data for immune checkpoint inhibitor in combination with chemotherapy. And you heard from Dr. Janjigian that the hazard ratio for this in the metastatic setting, in that case, it was CAPOX or FOLFOX, was 0.3. So really supportive of a biologic rationale. This is the Dante trial, where patients got standard of care FLOT with or without atezolizumab for locally advanced disease, similar population to the practice-changing FLOT trial. And all that we've seen so far is really the pathologic outcomes for this trial. You see that the pathologic response, complete response, over on the left, and very major pathologic response on the right, it parallels that Neo-Nipiga French trial I showed you, where we're looking at 60% plus of patients who have a path CR. In this case, chemo. It's unclear how much the chemo is contributing on top of the immunotherapy here, the other data we've seen with PD-1 and CTLA-4, but overall very supportive of the idea that this is a favorable population when IO is given in the neoadjuvant component. These are just a whole bunch of other trials, essentially using the same approach. Some of these are colon, some of these are rectum, some of these are stomach. Just to highlight that I think the field is really moving in across cancers for MSI-high disease to look at neoadjuvant IO. Everyone's rushing to get their data out in this strategy because it looks like the winner. There's a nice paper in JCO that looked across cancers from the MD Anderson group that essentially parallels everything I've shown you. So really, this is, in my opinion, a viable strategy, even though we don't have phase 3 data yet. All right, so what can we tell you when you go back to see your patients in the clinic? So it's worth testing. This is a biologically different subgroup. They have a better prognosis. It's somewhere in the 10 to 20% of non-metastatic patients. They don't benefit from our standard perioperative therapy. We don't have as much data for FLOP, but from MAGIC and Classic, this looks like a solid trend. We've seen from phase 2 data that neoadjuvant IO is very favorable outcomes in terms of pathologic response rate and early event-free survival. We don't know the optimal strategy, and certainly 585 and the MSI-high population from that and Matterhorn will maybe shed some additional light, but IO incorporation, whether it's with chemo, dual checkpoint, or monotherapy, are all something that should be strongly considered. All right, I'm going to move out of the MSI population into the rest of the people. So here we have essentially a GE junction adenocarcinoma, which is typical biomarker profile, mismatch repair intact, PD-L1 is low positive here, and we don't know the HER2. We see no evidence of distant disease, just a couple paraesophageal lymph nodes, and this is a T3N1 by EUS. So there's a lot of heterogeneity in how people around the world approach this problem. And I think this is kind of a question that I put in partly because I'm curious. So in surgically resectable, clinically node positive esophageal adenos, you can think of GE junction here too, I guess. What is your current approach? All right, so this is interesting. So 28% of people said they're going to give neoadjuvant chemo with cross. 55% they're going perioperative with FLOT. 10% pretty much split evenly between FOLFOX, chemo RT, and induction chemo followed by chemo rads. I'm just going to give you the updates in the data, and then this is something we can have in the discussion. But we saw the updated ASCO GI with the essentially final overall survival for Neoadjus. This was a trial designed a while ago when the standard or a standard was MAGIC, and another standard was cross. And they essentially were asking the question, which is better or which is non-inferior to the other? Is one non-inferior to the other? And so this was primarily esophageal adeno and upper GE junction, but it did allow CWER3 patients. And you can see that it was stopped early because of the futility analysis, which was planned. And patients were randomized to essentially the two dominant strategies, neoadjuvant chemoradiation, which really standard crossed the same way it was done in the trial to 4140. I think a lot of us in the US give RT to 50.4 as sort of our standard when we use radiation. And then most of these patients got ECX, and then protocol was amended to allow FLOT as that data emerged. Primary endpoint here was overall survival. So here is the final 3-year survival data. And really what you see is there was absolutely no benefit to either strategy. These are essentially identical survival curves. The 3-year survival rates of 55% and a hazard ratio is exactly at 1.0. One thing, and this paper kind of got buried, but I thought it was kind of interesting, so I'm going to share it here. It essentially is asking a question of, does it mean more to have a pathologic complete response with chemoradiation or with chemotherapy? The idea that is, if you aim radiation right at the primary tumor, you're probably going to have a higher path response rate because you're giving a local therapy. Where if you have a complete response with chemotherapy alone, that means you're testing the biology, and the tumor was really intrinsically sensitive to the therapy that you gave, not augmented by a local regional therapy. And here, I think the data, and these are matched patients from a large retrospective international set, what you're seeing is that the 5-year overall survival, so the cures, and you see the shape of these curves separated relatively early, around a year, a little less than a year, and then they stay and get further separated. And it's the 5-year overall survival with neoadjuvant chemotherapy, 87% versus chemoradiation with 75%. This is statistically significant. And then really interesting is that chemotherapy, the effect on the primary could potentially be extrapolated to the micrometastatic disease. That's what our patients are dying of, is recurrence. So they asked an interesting question and said, what about the distant recurrence-free survival? So essentially the development of metastatic disease. With neoadjuvant chemotherapy, a much larger proportion of patients were alive without the development of distant metastases than with the neoadjuvant chemoradiation arm, which sort of, in my mind, supports the idea that perhaps better systemic chemotherapy may be the preferred approach. It's just an orthogonal piece of data to support this total body of literature. And so I'd encourage people to take a look at this paper. It's quite interesting. It's not a journal that maybe we all follow in the annals of surgery as medical oncologists, but really quite well done from a really group. So kudos to them. All right, so patient gets cross, they get an esophagectomy. You see that they have relatively limited response. The tumor is still PD-L1 positive. Now they're asking about expectations. What do you tell this patient who has persistent disease after neoadjuvant chemoradiation? All right, so 41% of people said that median disease-free survival is around 11, 12 months. Trials show adjuvant chemotherapy improves survival, and median overall survival is about 5 years. So the answer is B in this case. All right, an emerging answer. So the answer for that prior question essentially comes from Checkmate 577, and I think Lizzie will talk a little bit more about this, but just pay attention to the control arm with essentially that population. All right, so you had sent a ctDNA test prior to the discussion of adjuvant nivolumab, and patient comes in 8 weeks later. So what do we know about ctDNA and localized disease? So this is me presenting Lizzie's data to her. But it is used to highlight an important point, is that as we all age, we accumulate somatic alterations, primarily in our white blood cells, so lymphocytes primarily, and this is CHIP. These are things, oftentimes P53 mutations, DMT3A mutations, that are picked up on ctDNA assays and can be misclassified as tumor-derived mutations. If you don't filter out by sequencing the white blood cells, you actually have a less prognostic assay that performs not as well. So you see the hazard ratio dramatically different between assays that involve CHIP filtering, where now you're removing the people who just had CHIP, and what you're comparing is people who truly had tumor-derived alterations versus people that didn't, and you see that there's a wide difference in the survival. So basically, Lizzie was faster than me, and we tried to do a very similar analysis to what she published and showed a very similar finding. So this is a tumor-informed assay looking at ctDNA in locally advanced and localized gastroesophageal cancers, essentially showing the same thing that's really now been shown in almost every tumor, which is if after the end of curative therapy, you have a ctDNA test that is positive, you are at an extremely high risk of recurrence. In this case, you see the very large hazard ratios, but essentially in our data set, it was about 85% of people who had a positive ctDNA assay after going through everything recurred. It might have even been 100% if we had more follow-up and more data points, but certainly is a very, very strongly independent bad prognostic feature. So this is just really briefly on 577. I think everybody's seen this data. In the interest of time, let's go to the next slide. But this is the answer to the prior question. So patients who get neoadjuvant chemoradiation containing regimens and have residual disease at the time of surgery, you're essentially marking a high-risk population. They had tumor that was not completely eradicated, even when you gave a locally directed therapy like radiation. And so if you see the control arm, the median disease-free survival is 11 months. So without anything, these people basically less than a year, half of them disease will be relapsed. This is the answer to the prior question. That's where the 11 comes from. The addition of adjuvant nivolumab doubled this disease-free survival from 11 to 22. So this was an advance for this patient population. If we go back to the biologic rationale, you might even wonder if patients had gotten concurrent chemoimmunotherapy or chemoradiation with immunotherapy in the neoadjuvant setting and then adjuvant, would we have seen even better numbers? We don't know the answer to that. There are some trials. There's an ECOG Alliance trial ongoing that sort of addresses this question. This doesn't benefit everybody, just like we've seen from Yelena's presentation about looking at the subgroups and the biomarkers and who's really benefiting. Certainly PD-L1 does look relatively predictive here as well. So in the people in Checkmate 577 who had the highest PD-L1 expressing tumors, you see the hazard ratio and the median disease-free survival. There you see a hazard ratio of 0.6 and a median disease-free survival of almost 30 months, which is great. And then people who cleared their nodes tended to do a little bit better. And then if you had pathologic downstaging, there was a little bit of improvement. All right, so back to our case. Gets a year of adjuvant Nevo without incident, now comes in with a CT 5 months after completing adjuvant Nevo and has metastatic disease. What do you do now in this increasingly common scenario? All right, so 56% of people are giving FOLFOX or CAPOX with PD-1 in someone who recurred about 5 months after finishing Nevo. And then, interestingly, 22% of people are giving Ipi-Nevo, and 17% are giving 5-FU oxaliplatin alone.